I wasn't quite sure. When I sat down to do the talk, what the audience was. I didn't know whether a bunch of rehab people and physical therapists or it was all surgeons. And so I originally sort of had the whole gamut of spondylolysis and spondylolisthesis, which is something we see a ton of in kids. Like every other child who's on a soccer team seems to get spondylolysis. But when I found out the audience was more surgically oriented, I switched to talking, I think we're going to talk about high-grade spondylolisthesis. How do I advance this thing? So unfortunately, I have to go like 30 slides into this. What do I point at? Do you know?
Well, it's HD.
So a lot of this was talk about spondylolysis, which I'm just going to skip.
Make 3 good points for those of us who aren't.
Okay. If you have a kid between the age of 5 and 15 who was on the soccer field or at the gym playing basketball or just playing with his friends, and all of a sudden his lower back hurts and he has to come off the field, what does he have? Okay, here are your options. Lumbar strain, disc herniation, discitis, psychogenic illness, and spondylolysis. Okay, I'm going to give you one more hint. It lasts more than 1 week. When he sits down and watches TV, it doesn't hurt. But every time he goes and plays it, he has low back pain. And he can't really finish. He can't really practice anymore because his low back hurts. What does he have? There's only one answer. Spondylolysis. And he never had back pain before. So does he have an acute spondylolysis or a chronic spondylolysis? Acute, okay. If you get an upright x-ray, what will it look like? Huh? A week into his symptoms. Huh? Yeah, it's going to look normal. Almost certainly it's going to look normal. Okay, let's say he had a little bit of back pain on and off for 3 months, and then you have the same story. You get an upright x-ray and you see an isthmic defect. What does he have? You can see the isthmic defect and a grade 1 spondy. And he's had some back pain for 6 months. What did he have? He had a flare-up of his spondy. It's possibly as a second level, but probably not. So that first patient, they've had pain for 3 weeks and they never had it before, and they have a normal x-ray. What do they have? Acute spondylolysis. What's the treatment for a tibial stress fracture? How many of you are neurosurgery oriented? How many are orthopedics oriented? Okay, what's the treatment for a stress fracture of the tibia? What? It's rest. Okay.
I'm a neurosurgeon.
Okay, so there's tons of people that get stress fractures, okay? In every other part of the body where you have a stress fracture, it's a given that the treatment is rest. We don't treat tibial stress fractures with physical therapy. We don't treat stress fractures of the pelvis and proximal femur with physical therapy. We treat it with rest. And if you rest a stress fracture, it will usually heal. And so that first patient, if you say, sorry, you just stop. You have to stop everything and rest and take it easy, which is pretty hard to do in young boys in particular, but they're all going to be professional athletes, so it's even harder because the parents think if they miss one practice, they're going to not make the Olympic team or get a college scholarship. So it can be hard convincing them. But if you rest in acute spondylolysis, it will heal most of the time, 80% of the time. if you don't, and you just let them be active and treat it like the typical lumbar strain, which is what most primary care people are taught, because they learn a lot about adult lower back pain, but they don't learn much about kids' low back pain, which is surprisingly common. So they treat it like adult low back pain, which is therapy and anti-inflammatories, and try to stay active. And what that leads to is a chronic isthmic defect and a chronic pseudoarthrosis. And after 3 or 4 months, when you have that, no matter how much rest or brace or whatever you do, the bone will never heal back together. So you have a mechanically bad back already, right? What's a natural history of someone who has a chronic isthmic defect and a grade 1 spondylolisthesis at age 15? You see, in the pediatric orthopedic world, the pediatric orthopedists who don't see adults think that that is not a problem, because very few people have major problems with it. They can do everything. They might have some achy back pain, but they never need surgery or anything major. But what percentage of your 20 to 45-year-old people that have really bad back and radicular pain are isthmic spondy patients that develop severe disc degeneration and spinal stenosis? It's a really high percent, I think. I mean, I remember that from practice. When I think of the patients we had to do decompression and fusion in their 20s to 40s, a lot, like 50% of them probably with good indications were spondylolisthesis, isthmic spondylolisthesis patients. And that's 10 times higher fold incidence than the prevalence of spondylolisthesis in the adult world, which is about 5%. So even though they say it's not a risk factor and so forth, if you just do the math, it's really a risk factor. So I personally think that if you see those kids, you should make them rest and heal it up with a couple months of rest so they have a normal mechanical back, and then go back and then do the therapy after they're healed. I think the therapy is really important, but not acutely. I think it should wait until the bone's healed, like you would with any other stress fracture. That's my key point, because there's lots of little kids that come in with a week of back pain. They don't have a lumbar strain. If they're 4, they either have chronic constipation or leukemia. And this is why I brace teenagers, because this is what they do with spondylolysis. So this is kind of what we talked about. By the time they leave the pediatric world, I don't know if this thing gets closer, this is all they have, and they don't really have much problem. And then you see them like this, and they have disc degeneration and a grade 2 and chronic radicular pain. Okay. So we're going to go over this. The chronic isthmic defects, we just treat symptomatically. Okay, so something more interesting to the surgeons, high-grade spondylolisthesis. So here is a patient with spondylolysis, and they're going to progress to this grade 1 spondylolisthesis. Then they're going to turn into that grade 2, and maybe 1 in 100 is going to turn into a grade 3. But is this what leads to this? For the fellows? No? Okay. Because I think a lot of people think it is, and it's not. These patients with really high-grade spondylolisthesis, they are generally never seen before. They just walk in, or if they can walk very well, with a really weird gait and a lot of back pain, and they're walking weird. And they present, and they're already there. That's the first time they come in. They have this, okay? And they're rare, but this year I've seen like 10 of them at Children's. And it's something, every time you look at that x-ray, what do the surgeons think when they see this x-ray? Anybody? Oh, slam dunk. This is going to be great. Rod?
No, I think for me, so
And what are you most worried about when you do if you're going to do surgery on this?
So, I mean, for me, it's always it's like, C5 in the neck, it's always L5 in the lumbar spine.
What, so you're worried you're going to get an L5 radiculopathy doing surgery, right?
L5, no, palsy. So it's easy to knock out L5.
Yeah. Okay. And what did you learn about why that happens?
So I used to think that somehow the L5 was special. Like
It is.
C5. But I think it's just like C5. I think because the tibialis anterior gets most of its innervation from one nerve root, that it's clinically more devastating for the patient. Whereas, other nerve roots, other muscles get multiple nerve roots. So if you knock out one, they tend to compensate.
Yeah. And how about the fellows? Any of the fellows? What's the classic description of why people get L5 radiculopathy when they have surgery for high-grade spondylolisthesis?
I didn't know that it was well described. I thought it was theoretical.
No. Like every series you ever read about, the biggest problem is.
No, but I'm saying that the actual mechanics of it.
Yeah. Well, so you're not old enough to realize that people figured out that it has been attributed to L5 nerve root stretch if you do any reduction. So first of all, they're not progression of isthmic spondylolisthesis. They're usually dysplastic facets or short vertebral bodies. They usually are in kids where they had some sort of defect that led to a little spondylolisthesis when they were young, and the anterior end plate is soft and cartilaginous, and the mechanics wear down the front. So they get this rounded off joint, and they slip. And a lot of them have soft end plates when they're young, and a lot of them have ligamentous laxity. So they may have a syndrome. They may have neurofibromatosis or Loeys-Dietz or whatever, but they may be subclinical, just really loose kids, right? And that leads to this. And they don't seem to have any symptoms until it's really advanced and they get irritation of their nerve roots. And in most isthmic spondylolisthesis, when you do surgery, let's say at L4-5 or L5S1, in a person with a grade 3 isthmic spondylolisthesis, the central canal, you don't have stenosis, right? You probably have foraminal stenosis because the lamina gets left behind. In most of these, it's different. You have to look very carefully if you're going to do surgery because a lot of them, they have dysplastic facets, and the lamina has actually come way forward. Even though the pars may look elongated, the lamina is dislocated into the canal at L5S1. So you can't do your typical big wild gill laminectomy and just rip the whole thing off. You have to be very delicate because when you get in there, there is virtually it's amazing to me that their S1 nerve roots work because they're just nothing. They're just threads of nothing right under the lamina. So first of all, you have to be really careful doing that. And so most of them, as I was going to say, they just present like this. This is a 3-year-old that I saw a little while ago. And what do they look like? Well, they look like this. They walk in like this. You know them. As soon as they walk in, you can see it. And if you look at their back, they have this verticalized sacrum and this global lordosis above it compensating for it. And it's usually shifted more on one side than the other. So they have this list, and it's called the Phelan Dixon gait. And people have attributed it to tight hamstrings. They walk like this. So do you hear tight hamstrings with high-grade spondylolisthesis? Who thinks that it's tight hamstrings? There's something about spondylolisthesis that gives people tight hamstrings. Rod, I'm picking on you. This thing doesn't work.
I think it's related to I think it's related to their spinal balance.
Anybody else, one of the fellows? You're always taught they have tight hamstrings, right? You sit them down, you can't straighten their legs out. Yeah. Well, when you sit them down and do a straight leg raise on them, you can't, right? You have lean back there. So what does that remind you of? You do a sitting straight leg raise and they lean back and say, "Ow, my leg hurts." What does that remind you of? Okay. What does that from the disc herniation? Yeah, nerve root compression. So I think all this tight hamstring stuff is baloney. I think their nerve roots are really tight over S1, and they flex to take the tension off, and they walk on their toes. A lot of them are toe walkers too. So I don't think it's tight hamstrings, even though the book says that, and it looks like tight hamstrings. It does look like tight hamstrings, but so does everyone with sciatica and nerve root tension signs, right? They have tight hamstrings, but they don't. They have radicular pain. They have sciatic tension signs. Okay, so back when you were just a glimmer in your mother's eye, we didn't have instrumentation. And so people did in situ posterior fusion, right? And they got a fusion. Usually they'd go to L4, and usually it would fuse. And did that take care of the problem in high-grade spondylolisthesis? No, because they would progress even with a solid fusion. So they realized, you're going to have to do something more, get an anterior fusion. So they started doing some sort of grafting anteriorly. And then the gait and the appearance was bad, so they thought this slip angle thing was a big deal. So they'd put them on a risser table and hyperextend them with the in situ fusion and put them in a cast. So if it's L5 nerve root stretch, would just hyperextending them in a cast give them an L5 radiculopathy post-op? No, I could never figure out. We'd have patients come back in a cast, extended. All you do is put a little bone graft posteriorly and they'd have an L5 radiculopathy post-op. Like, that didn't make any sense. I can't believe we got enough traction with the risser table to do that. Well, then came along posterior instrumentation, and we thought, okay, well, we can keep it from progressing if we do posterior instrumentation. So now we'll do posterior instrumentation and fix it, and we're not going to do anything in the position. We're just going to put the screws in, and we're going to fix it and graft it, and we'll hold it, and it won't progress, and we won't have to do an anterior thing, and they won't have an L5 radiculopathy because we won't change their position. So that's what we did, and they got an L5 radiculopathy. They did do the laminectomy, foraminotomy, put the screws in, try not to change the position at all, and they'd get an L5 radiculopathy. So we weren't stretching them, even though all the literature says it's stretch. Okay, so then, and the other thing is, even with the posterior instrumentation, they would still progress, and they'd wear out their anterior disc because it would still flex a little bit. So then we came up with, okay, we don't want to reduce it or put any traction on it because you'll screw up the L5 nerve root. So we'll do the Bowman technique where you fix to L4, L5, S1, maybe the sacrum, and you do a transsacral graft, right? You go here at S2, go down the side, and you go right through the body with a drill. Have any of you done it? It's actually a nice technique, works pretty well. You drill right the guide pin, you get a ACL reamer guide right through there, and then you put a fibular allograft, or if you want to spend some more money, you can put a mesh cage in packed with bone, and that worked pretty well. But they still had that weird posture and appearance. It would improve a little bit just from stabilization, and with the decompression they get better, but still, even some of those patients would get an L5 radiculopathy, even though you're trying really hard not to do stretching. But everyone says it's stretch. So how do you not stretch and get a reduction of the slip angle? You can do a Gaines procedure. Anybody know what a Gaines procedure is? You go in the front, you take out all of L5. Right down, you take the disc. Then you go in the back and you instrument L4 and S1, and you put L4 on S1 with some graft. And you lay them in bed or cast for a couple months, and they heal. And you get a perfect spinal balance, their sagittal contours, everything returns, and they all get L5 radiculopathy. Most of them. They most of the time it'll come back pretty well, but they usually, and lots of times it won't show up for 2 or 3 days. Okay. That one is a little different, I think. So then people now, they're used to doing all this T-lift stuff for less deformity. So now some people do instrumented, posterior instrumentation, fusion, T-lift, and try and reduce it. And what's everybody afraid of when they reduce it? You're going to get a radiculopathy, right? Because of why? Because of stretch. Okay. So what do you try and do to not get the L5 radiculopathy? Okay, so all of these series have high rates of L5 radiculopathy, even if you don't stretch it. Why? Okay, so what are our goals? We're going to reduce the slip angle. We want to get it to fuse so it won't progress and they'll feel better, because a lot of the pain is just the degenerative wear and tear in the disc space. And we want to avoid radiculopathy. And we want to avoid pithing them at L5S1. So we're going to be really careful when we do their gill laminectomy. Then we're going to do some foraminotomy, but we already talked about being really careful. But doing a foraminotomy here, how do you feel about doing that foraminotomy from the back? Tim? Really tough, because you just got this nerve root that's a ribbon stuck in between the pedicle and the disc space, and there's bone right under the disc space, right? So it's really tough. And let's say you wanted to reduce this, and you pulled this back like this. What's going to happen? What's going to happen to that nerve root if you try and reduce this? What's going to happen to it? Okay, you stretch it like 2 millimeters, and then what? You crush the nerve root, right? You crush it. You crush it between the pedicle where it's sitting and this disc and the overlying S1. And even with a lower grade spondy, it still looks like this, a grade 2 and a grade 3, because the disc is degenerated, it bulges, and there's very little space between the disc base above and the pedicle where the nerve root's sitting. So if you get any more lordosis or you try and reduce it, you will crush the nerve root. So you've been taught your whole life, don't stretch, because that's what's get us. But so now we're going to go a little further. What do you want to do with this patient? That X-ray I showed before. The high-grade spondy. Inside to posterior fusion?
Don't operate.
Don't operate, okay. They can't do anything. She has terrible pain running down her legs. She basically can't do anything she wants anymore. She can barely go to school. Okay, you want to do an anterior and posterior fusion? Anterior is impossible because you can't get to the disc space. All you can do is drive something through there, right? It's below your approach level. You can't come from this unless you know how to do transanal surgery. So you want to do a transsacral graft and then posterior instrumentation? Nobody wants to do anything. Patient can't do anything. What do you want to do? You want to do a Gaines procedure? It's fun. It's a really cool procedure. It works great except the L5 radiculopathy. Or do you want to reduce it and do what you do for your regular grade 2 spondy? Try and do a reduction in interbody graft. What are you going to have to do that? Stretch, right? You're going to have to stretch. You're going to have to stretch. So okay. That's what we do. And it's shocking to me, all those things we went through, trying to avoid stretch, everybody getting an L5 radiculopathy. I've done like over a dozen of these with these high grade ones. And none of them got any radiculopathy. It's shocking. Now they're kids, so they're probably a little more resilient than some of your older adults when they have that. And I think it does depend a little bit on how you do it. So I like to do a midline laminectomy to protect the S1 nerve roots and the S2 and 3 nerve roots. And I don't try and do much of a foraminotomy to start with because it's impossible to really do it without banging up the L5 nerve root. It's so far down. I do primarily get into the disc space and do a little bit of discectomy to get rid of some of that soft tissue in the disc space and know where your T-lift approach is going to be. You set up for the T-lift. Put your instrumentation in. In some kids, I do use L4, and I go to either S1 or sometimes I'll use SAI screws or pelvic screws in people that it's going to be a little harder, or I don't trust that it'll be easy to reduce it. Then we distract. And I think this is why we're not getting L5 radiculopathies. We distract very aggressively across L4 to S1 first. Use the screws you don't really need as much. Push apart at L4, S1, really, really distract. And then I like to use polyaxial screws in both S1 and L4 and 5. And I actually use reduction screws. I know there's other ways of doing it, but I really like the reduction screws because you can distract at the same time as you slowly tighten them. So if you have them both at L4 and S1, you can distract and have the rod still sitting up. So you can partially reduce using L4. You have the reduction screw and the rod sitting, a couple centimeters above it. And you can adjust how high the rod is by tilting the S1 screw and then locking it down carefully before. So you have the reduction screw. This is the seat of the reduction screw, and you have the rod sitting up here, and you've distracted, and you're holding it distracted while you reduce L4. And then you distract and do the same thing at L5. And so distraction, what you're doing is you're taking this and getting it here first and opening up that foramen. And then you really much more aggressively do interbody prep. So you take out the disc space really aggressively. Maybe in some cases you have to take your osteotome, go here and get off the front to make this a little shorter and get rid of the rounding and get a flat surface and really aggressively get rid of all the disc material. And a lot of these have a big osteophyte that sticks off the back. It's a traction osteophyte from the annulus that you have to take out. Otherwise, that osteophyte is sticking up into the canal. And then, so you've distracted. You do more interbody prep. Then you pull L5 back while you're distracting it. Then you put your interbody cage in. Be sure it'll fit. You don't have to get a full reduction. You just have to get it where you have enough of the body, the bottom of L5 touching S1, that you have anterior support. Because when we tried to do reductions with posterior only support, they all failed. Either screws would break or the rod would break, or they'd pull out. That was tried for a long time before there was interbody stuff. So you need that interbody support. So you get that in, you've distracted at 4, 5, then pull back. Very careful that you've distracted the whole time. Pull back after you've done the interbody prep. And that's to get rid of all that stuff in the foramen below the pedicle and make that space between the pedicle and S1 big. And then after the cage is in, you compress to the cage. So you've got a really nice stable construct. And then you look at your L5 nerve root, and it looks like you could drive a truck through the foramen. You can see this whole nice, huge L5 nerve root with no pressure or tension or anything on it. And I've been kind of shocked because we used to get L5 radiculopathy doing everything. Everything we did, we got L5 radiculopathies on a very high percentage of people, and like I haven't seen it in like 8 years or something. So, yeah. It's usually bilateral. I don't know. Do you guys have any experience? Some of you have been around a long time, and some haven't. These are pretty rare, so most people haven't seen like 1 million of them in their lifetime.
described, probably somewhere around 15, maybe over the course of my career, maybe 20. And I think it's very important to reduce the angle, slip angle. I'm less aggressive about the actual slip. And, you know, trained with Henry Bowman and kind of used his technique of leaf interbody. And I've liked that. I've had a couple non-unions, but
The transacral thing?
transsexual,
Yeah.
But you have to leave, in order to do that, you have to leave the slip in place.
You can't pull it back. Yeah, if you get it back to grade 2, you can't really do it.
That's right.
Yeah.
So,
This usually you will get rid of the slip angle, or at least about as good as you can.
Yeah.
Pretty close, and you get interbody. You get interbody support. So often you don't need pelvic fixation. It depends on the quality of the bone and how easy it is to pull it. I was thinking of doing a Bowman on this, and I like to put posterior instrumentation in first before I do take out the front in case I have to stop.
Right.
And I just said, oh, let's see what would distract, and it went, it went completely distracted out to length with L5, you know, up here. This was like up here, just going, and I monitor them all with a full motor sensory monitoring. The EMGs aren't very helpful. I don't know if you're used to doing it. Anyway, yeah.
With staff who would do an ALIF on these and as standard. You're saying
You mean they do posterior and then do an A-lift and then go back and compress?
ALIF first,
Wow.
and then
How the hell did they get there?
so I
With a high grade? With a really high grade?
I don't know if you know.
Andy King, he's down in New Orleans, but he's pediatric, children's hospital down there,
Yeah.
but adult trained. And he really feels like he gets good exposure with the ALIF, and you can do that distraction from the front,
Yeah.
get it over the top, and pretty low incidence of radiculopathy as well.
I have not been, I haven't tried that often, but when you go in to do a bowl and remember to do a gains, you come in and look at, I don't know how to get it like this. They must have to take off some of this to get there.
That reduction gets that distraction, right?
Yeah. It's usually actually easier than you think from the back, but whatever.
sorry.
There was another question in the back. I don't know, the person way in the back, did you have your hand up a bit ago?
I was just going to say, I've done a few cases with Dr. Chapman with these, and the only other thing that he does is he puts a interbody cage at L4 or 5 in addition to.
Oh yeah, these are kids, and so all you have to do is expose them, and they fuse usually. So, yeah.
I'm sorry, I missed some of your talk but I was wondering, what specifically is it that you're doing differently that you think of with the L5 review?
The reason I kept going on about the stretch thing is because everybody learns don't stretch, which makes you think don't distract. And I think the biggest problem is when you try and reduce without distracting first, because I think you just cry. All you need, if you haven't distracted and you get any more lordosis than because most people are trying to get rid of the slip angle. So if you try and get less slip angle with this, like this, without distracting, the nerve root's sitting right there, and you just crush the nerve root.
Right.
So my point was, I think it's the most important thing is distracting at L4 and 5 before you ever try and really pull it back significantly.
Well, Wally, the sequencing is the key. Is the point. Distract first.
That's what I think. I mean, they're all, there's not that many cases, and we're not going to do randomized trials and stuff, but.
Of doing, manual approaches without skin and pad, that totally makes sense to me. My question is, you as a surgeon, how did you come to that sequencing? Was it just by accident, or was this a thought? I mean,
It's kind of weird.
all literature says,
Don't distract. Yeah.
yeah, exactly.
Because I'll tell you, it goes back to these kids that I would see just go in a cast to hyperextend to get their lordosis better, to try and reduce the slip angle with an inside tube fusion, coming back with an L5 radiculopathy, and I'm like, I don't get it. Like, why do you have an L5 radiculopathy? And this was back before you had MRs, and you really couldn't see the foramen on it. There wasn't sagittal and coronal reconstruction, so you never got. Let me go back here. You never got this picture. The first time I saw that picture on an MR, I went, oh, now I get it. And when everybody's taught not to distract because it's stretching the nerve root that gets it, it's hard to overcome that. This makes sense to me. And when I fit it with all those people getting L5 radiculopathies, when we weren't trying to do anything but get a little more lordosis, when I put it together, I just went, no, you just got to make room for the nerve root. And it was probably an evolution of doing adults with degenerative scoliosis that had 7 foraminotomies, and they still had radicular pain, and all you had to do was, and when you look at the MR, the nerve root's crushed between the pedicle above and either the pedicle or a disc space below. It's the same every time. There's no way you're ever going to decompress the root without pushing that side up and making the foramen bigger. So I think it was an evolution of that, and I just went, we're monitoring. I did it with really good spinal cord monitoring. I would distract, nothing, no problem. And I just kept doing it, and it was just shocking to me. Because it's what most surgeons fear it really, really, really badly. Now I'm doing kids, so they're more flexible and it's easier to do, and their nerve roots are probably happier to start with. But
They got a great sense of compressive radiculopathy.
I think that's what I think. Some of the gains and the other ones, I think they just get stripped for so long, like doing a ulnar nerve decompression with no blood supply for that long. Maybe I don't know.